Hi, it's Estella Ramirez-Reynoso, and this is my OB-GYN patient case. My patient case is on a 24-year-old female who presents to the clinic for an evaluation of an abnormal menstrual cycle and facial hair. The patient reports feeling worried about fertility and weight gain as well. The onset of her issue was at 21 years old. It started with oligomenorrhea with cycles lasting 45 to 60 days and a worsening hirsutism, acne, and a 20-pound weight gain. She noticed that symptoms do improve with a low glycemic diet and exercise, and no intermenstrual bleeding or pelvic pain was noted. Her past medical history, she states she does not have too much of a medical history. She reports no hypertension, diabetes mellitus, or thyroid disease, and her menarche started at 13 years old with regular cycles until about age 21. She has had no children. She is G0P0, and she states she does not have a history of STIs, and all her pap smears have been normal. Medications and allergies. Patient reports that she does not take any prescribed medication, but she does take ibuprofen as needed for some pain during her menstrual cycles. She reports taking a daily multivitamin, and she reports no drug allergies or food allergies. Patient states she does not take oral contraceptives, and she uses condoms as contraception. Social history. She is a college student. She has a part-time job, and she reports financial stress. She states she does not smoke or use illicit drugs. States she consumes alcohol 2 to 3 times a week, and she is sexually active and uses inconsistent condom use. Family history. Patient reports her mother has diabetes mellitus type 2, hypertension, obesity. Her sister has PCOS, and her father has hyperlipidemia, and reports no history of gynecological malignancy in her family. Her review of systems includes the patient reports gradual weight gain. She has low energy, reduced exercise tolerance, and she denies fevers, chills, or night sweats. Her skin and hair. She notes that there's an increased facial and abdominal hair, and she has persistent inflammatory acne. She denies that she bruises easily or striae. In regards to endocrine, she reports an increased thirst and frequent urination when she is stressed. She denies any heat or cold intolerance. CV and respiratory. She denies any chest pain, palpitations, or shortness of breath, or exertional dyspnea. GI. She denies nausea, vomiting, or abdominal pain, or change in bowel habits. GU and reproductive. She does report oligomenorrhea with cycles every 45 to 60 days, mild dysmenorrhea, and no dyspareunia. She denies abnormal vaginal discharge or any postcoital bleeding. Neuro and psych. Patient denies any headache, visual changes, or galactorrhea. She reports intermittent sadness and anxiety about her body image and fertility. She denies SI and reports that her sleep is often fragmented when she is stressed about school. During her physical assessment, the patient was alert and oriented. She didn't seem like she was in acute distress. Her vitals were within range, and she did show an increased BMI at 30.8. She had mild facial acne and terminal hair on the chin and lower abdomen. She had some velvety hyperpigmentation. along the posterior neck, which was consistent with acanthosis nigricans. She didn't have any striae or proximal muscle weakness, and her thyroid was normal in size and had no nodules. CV and respiratory exams were within normal limit. The abdomen was soft, non-tender, without palpable masses. A bimanual pelvic exam was done, and it showed a normally antevertebrated uterus, which was just mildly enlarged, non-tender ovaries without any masses. The breast exam revealed no masses, no nipple discharge, and there were no skin changes. Diagnostics, when a patient shows oligomenorrhea, the first assessment or lab, like we learned in class, is a pregnancy exam. So an HCG was run and it was negative. We also checked LH and FSH ratio, which was 3:1. Her A1C was at 5.8%, and she had an impaired fasting glucose. An ultrasound showed that she had polycystic ovarian morphology, and her TSH and prolactin were normal. Differentials for this patient are PCOS, because she meets 3 of the Rotterdam criteria. You need 2 out of 3 for PCOS to be diagnosed. Hypothyroidism, which was ruled out because of her TSH levels, and she also denied cold intolerance or constipation. Hyperprolactinemia was also ruled out because although it may also cause oligomenorrhea and galactorrhea, normal prolactin was present, and there was also no breast discharge, so making this differential a little more unlikely. Cushing syndrome was also considered because of the central obesity and menstrual disruption, but there were no striae, muscle weakness, or functional hypothalamic amenorrhea was also considered, but since you usually see low body weight with this, it's highly unlikely. These are the ICD-10 codes that I used for this case: PCOS, irregular menstruation, obesity, and it was an established visit with lab codes. The primary goals in management of this patient are to regulate menses, reduce hyperandrogenic symptoms, and address emerging metabolic risk and support the patient's reproductive goals in accordance with international PCOS guidelines. The first line is always non-pharmacological, and it would include a well-balanced diet, daily exercise, and weight loss. When it comes to pharmacological therapy, you would begin with combined oral contraceptives to regulate this patient's cycle and to help with hyperandrogenism. You would also include metformin for impaired glucose and metabolic risk. And if her hirsutism continues even after being on combined oral contraceptives, you can consider medications like spironolactone to help with that as well. And of course, when being on this medication, you want to make sure that the patient is on a reliable contraception method. And of course, you could also encourage the patient to possibly consider laser hair removal treatment. As far as patient education, you would begin by educating the patient on the fact that PCOS is a chronic endocrine disorder, and it's actually one of the most prevalent endocrine conditions in women of reproductive age. So she shouldn't feel alone. This happens to a lot of women. Symptoms, you also want to educate patient on the fact that symptoms are manageable with lifestyle changes and medications, and reinforce that fertility prognosis is generally good. And you also want to discuss long-term risks like diabetes mellitus type 2, dyslipidemias. You want to make sure that the patient knows that early management helps prevent these. Follow-up plan. My first follow-up would be at 3 months. You want to assess medications, their cycles, and any side effects that she may be having with those medications. At 6 to 12 months, you want to repeat labs like A1C, lipids, CMP, pretty much the diagnostic plans that we did at the beginning, doing them again to see how the patient is improving. And you also want to refer them to an REI if they are pursuing pregnancy, because although the prognosis is good, it may be a challenge. So as you might have caught on, the diagnosis for this patient is polycystic ovary syndrome, which, as earlier mentioned, is a chronic endocrine disorder, one of the most prevalent endocrine disorders of women in reproductive age. It is a disorder where there is hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. But although it's in the name, having polycystic ovaries isn't necessary for this diagnosis. This diagnosis is also associated with insulin resistance and cardiometabolic risks. So it's very important that it is diagnosed early to have the best long-term results. And lastly, the criteria used to diagnose PCOS is the Rotterdam criteria, which includes 3 things: oligomenorrhea, biochemical and or clinical signs of hyperandrogenism, and polycystic ovaries. So the criteria states that a woman must have 2 out of 3 of these things. So this is why, although polycystic ovaries is in the name, you don't necessarily have to have polycystic ovaries to be diagnosed with PCOS. You just need 2 of these criteria. So you could have PCOS without polycystic ovaries, and just because you have polycystic ovaries doesn't mean you have PCOS. Here are my board style questions. And here are my references. Thank you.